Good morning, everyone. We're going to be focusing this morning on part of ECG reading, and specifically to be able to recognize at the end of this 25 minutes or so talk, to be able to recognize sinus, atrial, and junctional rhythms by simply look at the 12-lead ECG and P-wave morphology. So the topic this morning is sinus, atrial, and junctional rhythms. Thank you very much. This is just to highlight that the vascular supply, the arterial supply of the heart muscle, and the venous return, all the vascular system is epicardial. And this is in contrast to the electrical system of the heart, which is mainly endocardial. In this drawing here, you can see this is the representation of the sinus node, which is actually the exception, and that is an epicardial structure. But when it comes to the AV node, to the right bundle, and to the left bundle, these are all sub-endocardial structures. Why is that? Because I think the electrical system is more important than the plumbing system. At least that's what I tell my interventional cardiologist partners. But you can see the relationship between the blood supply, the arterial branches, and the electrical system. So those coronary arteries with the right coronary artery here, the left coronary artery with the left anterior descending artery, and the left circumflex artery, you can see they don't only provide the blood supply to the heart muscle itself, they also provide specific branches to supply the different parts of the electrical system. So in this case, the proximal part of the right coronary artery is giving a branch to the sinus node, another branch to the AV node, and you can see the branches here to the bundles. And the left anterior descending artery from the left coronary artery giving the main supply to the bundles, the right bundle and the left bundle. This is an important relationship to understand before we go and start learning how to read the ECGs and different kind of supraventricular arrhythmias, because if you happen to have an acute myocardial infarction and block in the proximal portion of the right coronary artery, you can imagine why you would have a sinus node arrest or sinus bradycardia. And if you block the supply to this artery, why would you have a complete heart block in the setting of inferior myocardial infarction associated with occlusion of the right coronary artery? And it also explains why you might have a left bundle or right bundle branch block when you have acute anterior myocardial infarction. If we intervene and open the artery, it is not surprising that the blood supply would resume and conduction would return, and you would not need or may not need to go ahead and put a permanent pacemaker in place. This is just something I want to highlight before going further with the electrical system. Another thing I would like to highlight, and this is basically the right side of the heart. We took the free wall of the right atrium here and the right ventricle and opened them up. So we can see the sinus node here, again, the only epicardial structure of the electrical conduction system. We can see the AV node, the Hus bundle, to the left, to the other side, you go to the left bundle, and here the right bundle. If we do the same and open the left side of the heart, this is the left atrium, this is the left ventricle, you can see the big branching tree of the left bundle. It's important to realize that the right bundle is very thin and very superficial subendocardial, to the point when we do EP study and put a catheter in, just the fact it touches that bundle, it can create a temporary or transient complete right bundle branch block. If you have a pulmonary hypertension patient, he or she may present with a right bundle branch block. If you put a Swan-Ganz catheter in, you may have a right bundle branch block. So be careful with all these things in somebody who already has a left bundle. When you put a catheter in, you may create a complete heart block. Right bundle branch block, it is not a big deal. It's a common thing. It is easy to do. It's easy to have. But if you have a left bundle branch block, that is really something you need to be concerned about, and you certainly need to go ahead and do more workup than just an ECG. Even those patients with left bundle branch block who we do an echocardiogram, MRI, cardiac stress testing, and we fail to find a reason for it, they still don't do as well when they are followed for the long term. So this is again to highlight, right bundle, very thin, left bundle like a big branching tree. To simplify the electrical system of the heart, it's simply decided or divided into the sinus node, which is like the electrical generator and simple wiring system. The main cable is the AV node, and it's two wires. One goes to the right bundle, and one goes to the left bundle. So electrical generator, sinus node, and cable with two branches. If we look at it like this, I think it will be easy to read the 12-lead ECG and discern all kinds of supraventricular arrhythmia. 12-lead ECG, as we all know, it came because you have 6 limb leads and 6 chest leads, and that will give us the 12-lead ECG. To simplify it for you and to make it easy to look at the 12-lead ECG and quickly decide what kind of rhythm you have, I'm going to just ask, for the purpose of this lecture, to focus on only 3 leads. So lead 1, lead 2, and lead V1. If you focus on these 3 leads, and I think you will be able to read 90–95% accurately and very fast of all kinds of arrhythmia. Before reading the ECG, just like before relying on the recording of an arterial line, we need to zero that arterial line. The same thing for 12-lead ECG. We need to make sure that that 12-lead ECG recording machine is set according to the accepted standards. The 2 main standards are the paper speed, 25 millimeter per second, and the gain, 10 millimeter per millivolt. How do we know that? Every 12-lead ECG, and I hope you start looking at that, every 12-lead ECG will have that somewhere. The top, the bottom, the side, you will find it. In this case, see, limb leads have 10 millimeter per millivolt gain, chest leads 10 millimeter per millivolt gain. Speed, 25 millimeter per second. That square thing that you see at the beginning, and sometimes you see it at the end of the strip, that's simply a 10 millimeter per millivolt test. That's the machine test itself, gives 1 millivolt, it gets 10 millimeter. When you look at this, if it's 20 millimeter, that means you have double the gain. And if you see an QRS that suggests LVH, that's probably not an LVH. And if you see that as 5 millimeter, that's half the gain. And you may miss an LVH if it's present. When would I personally go from 10 millimeter to 20 millimeter? When we have P wave that's hard to discern, hard to see, then I double the gain. It's like looking at the P wave or the underlying atrial activity with a magnifying glass. The point is, look first at the gain and the speed. And how important that is? It is really important, because if you look at these strips I just got from our telemetry strips, quick look on the top, you see it fast. You have tachycardia here, heart rate about 100 beats a minute, here about 200 beats a minute, here it's about 50 beats a minute. So you say, okay, almost a Brady, normal range, really fast. But when you look at the speed, 25 millimeter per second is the speed for this strip. Well, that's not concerning. Heart rate about 95 to 100 beats a minute. This is the exact same strip. I made it 12.5 millimeter per second. The paper is very slow, allowing the QRS complexes to be inscribed closer to each other, and it can fool you as a heart rate of 200 beats per minute. And if you look here, the same strip, I doubled the speed, 50 millimeter per second. That fast paper speed make those QRSs farther apart and give us the impression of bradycardia. Why am I highlighting this? Because I've had consults for tachycardia and bradycardia where the speed was the issue. And you can see here the gain by looking here. This gain is not the normal 10 millimeter per millivolt gain. You increase the gain, you increase the amplitude of the QRS, and it gives you the impression of an LVH that doesn't really exist. So the ECG is the recording of the electrical activity of the myocardium. For simplicity, again, we'll try to simplify things without affecting the accuracy of ability to read the ECG with accuracy and speed. The heart divided into 2 muscle masses, atrial muscle and ventricular muscle mass. Activation of the atrial muscle mass will give us a P wave. Activation of the ventricular muscle mass will give us the QRS. As the impulse is going between the atria and the ventricles, It's going through the AV node with no muscle fibers. So you get isoelectric line. You have no electrical activity to record. And the two muscle masses are separated by the annuli, the AV valves, the tricuspid valve on the right and the mitral valve on the left. Those annuli are fibrous tissue and will not allow conduction between the atria and the ventricles. So normally the AV node is the only normal electrical connection between the atria and the ventricles. Again, to simplify it more, and for the purpose of deciding the rhythm, look at P, PR, QRS. Forget about the ST and T wave for now. Why? Because the ST and T waves are helpful to evaluate the blood supply. So plumbing is ST, T wave, electrical, P, PR, QRS. Normal intervals, quick way to figure it out. You have PR interval, usually one big box is the upper limit of normal. Each millimeter is 40 millisecond. When you say 25 millimeter per second, that's 25 millimeter per 1,000 millisecond. Each millimeter is 40 millisecond. 5 millimeter, which is the dimension of those boxes here, the big boxes, is 200 millisecond. The PR interval should be contained within that big box to be normal. The QRS duration should be 100 millisecond or less, which is half big box. So quick look, you'll find PR within a big box, QRS half or less big box. Then you're dealing with normal activation times. Here, just to highlight, this test, 1 millivolt test, gives you 10 millimeter. So most of us learn and probably continue to practice to look at the P wave first when we look at the 12-lead ECG. Again, I don't want to emphasize the importance of looking at the gain and the speed, but I would like you to start looking at the QRS first. And now we learned, if you look at the QRS, if it is 100 millisecond or less, that means it's narrow. Narrow QRS, we're talking about timing, the time it takes to activate the ventricles. To activate the ventricles fast, the impulse has to come down from the AV node area, down both bundles very fast. Think of the bundles as highway. You go really fast down that highway. And to go down both bundles to activate ventricles at the same time and finish the QRS in short time, you have to come down from the AV node, down both bundles. So narrow QRS, you have fast conduction through the AV node and the normal bundles, fast activation of both ventricles, and the QRS duration is certainly less than 120 millisecond. Normal is 100 or less. Again, less than 120, still considered narrow for all practical purposes. If you travel down the myocardium, not down the bundles, you're gonna go through dirt roads instead of going down highways, and you take longer time, and that's when the QRS start to widen. So anytime you have narrow QRS, you already established the impulse starts from this point down. So you have to be coming either from the AV node or above. The level above the AV node, that's where we call the supraventricular zone or region. So once again, narrow QRS, going down the AV node, and normal, fast conducting bundles, you have supraventricular rhythm. That's very easy and very fast. Look at the 12-lead ECG, narrow QRS. Now, your attention is shifted only to the supraventricular rhythm. You forget about this area. So to summarize, narrow QRS, you have supraventricular rhythm, and you are excluding bundle branch block. Again, when we evaluate the rhythm, we look at where the rhythm is coming from, to think of the electrical generator, where it is, and how is it being conducted, how it's traveling. And we only have the AV node and the bundles to think of. So you can divide the whole conduction system into a generator and two main wiring components, AV node and the bundles. So narrow QRS, supraventricular rhythm, and no bundle branch block. So let's dissect that further. Supraventricular rhythm, it's really limited options, either sinus or atrial or junctional, no other. We're not gonna have pulmonary rhythm or pericardial rhythm, one of these three. So let's see how we can quickly and accurately decide what kind of supraventricular rhythm we have. But before going any further, another simple rule. The bigger the muscle mass, the bigger the electrical activity we're recording or the deflection. And activation in the direction of the recording electrode will give us positive deflection. Activation away in the direction away from the recording electrode will give us negative deflection. If we know these two simple rules and we know the location of our recording electrodes and the activation, the direction of the activation wavefronts, we should be able to accurately read any rhythm problem the patient may have. So, supraventricular rhythm, sinus, atrial, or junctional. Sinus rhythm, again, I promise you all you need to look at is lead 1, 2, and V1. Sinus rhythm, the sinus node is located in the top of the right atrium. So the activation will be going from the right atrium to the left and from the top to the bottom. If we look at lead 1, which is recording between the right arm and the left arm, you can see activating the atria, if it's coming from the sinus, will be going in the direction of lead 1 and will be going in the general direction of lead 2. If it's positive in lead 1, that means you're coming from the right to the left in the same direction. If it's positive in lead 2, you're going in the direction of lead 2 from the top to the bottom. What is in the top of the right atrium? That's the sinus node. So if you have 12 lead ECG and you look at the QRS, it's narrow, we have supraventricular rhythm. Try to find the P wave in lead 1 and 2. Don't bother looking at other P waves for now. Positive in lead 1, it's coming from the right atrium. Positive in lead 2, it's coming from the top of the right atrium, that's sinus. So positive in lead 1 and lead 2, P wave, that's sinus P wave. Now the other options, if you have atrial rhythm, and atrial rhythm could be coming from anywhere in the atria, anywhere in the right atrium, anywhere in the left atrium. Sometimes it could be confusing when the spot of the atrial rhythm is close to the sinus node, making it difficult to distinguish, but we have other features we can rely on. Nonetheless, if you have atrial rhythm, whether it's left atrial or right atrial rhythm, we can look at it and evaluate it the same way. Look at lead 1 and lead 2, and in this case, let's evaluate the possibility of the rhythm coming from the left atrium. Now, activating the atria would be going from left to right. It's going to be in the opposite direction to lead 1. That will give us negative P wave in lead 1. And if it's coming towards the top, let's say from the bottom to the top, it's not going to be positive in lead 2, and we may record a negative recording or P wave in lead 2. So, as a rule, once again, let's look at this ECG quickly. Practice, narrow QRS, supraventricular. Options are sinus, atrial, or junctional. To be sinus, it has to be positive in lead 1, which is positive in lead 2, it's not. So it's not sinus. The option left is atrial. Junctional is the third option when you have supraventricular rhythm, and that's easy to figure out. If you're coming from the AV node area or from the junctional area, you will be going up and down at the same time. So the P wave will be hidden behind the QRS or shortly after the QRS. We learned a lot of times that when you see a P wave negative before the QRS, that's junctional. I think that's still called low atrial. Anytime you see a P wave before the QRS, it is not junctional, it's atrial. I've been doing EP for 21 years, never seen junctional rhythm recorded and verified intracardiac and surface ECG where P wave precedes the QRS in a visible way in 12 lead ECG. So having a narrow QRS with no P wave, that tells us it is junctional. And this is an example. Again, narrow QRS, supraventricular, option sinus, atrial, or junctional. No P wave, it can be sinus, it can be atrial. You're left with junctional. Sometimes when you don't have a P wave before a narrow QRS, it's junctional, you may be able to see the P wave just after the QRS. So to summarize, when we have narrow QRS, it's supraventricular rhythm. Look at lead 1 and 2. Positive in lead 1 and 2, that's sinus. Any other P wave morphology, that's atrial. No P wave, that's junctional. Any questions? Just tell me you guys are awake. Somebody.
We're awake.
Oh, okay. At least Patrick
Listening,
is awake.
just making notes. Sorry.
No problem. Thank you very much. We have at least 2 awake. That's good enough. Let's keep going. Now, this is a good display. All these are our patients, actually, strips, without violating any HIPAA. So this is ECG. You can see lead 1 and lead 2. Again, never forget the speed and the gain. In this case, you can see the speed, 25 millimeter per second. The QRS, you will get used to it. It is narrow. This is a big box. This is less than half big box, narrow QRS. Options are sinus, atrial, or junctional. If we look for P wave, we can see P wave positive in lead 1, positive in lead 2. That's sinus. Keep going, keep going, keep going. The P wave flips. When the change in P wave occurs, now we're moving from sinus to atrial. And you can see the P wave is negative in both. So it's negative in lead 1, so it's coming from the left atrium to be going towards the right. It's negative in 2, it's coming from the bottom up. So just looking at these 2 strips, not only we know it's not sinus and it's atrial, we know exactly where it's coming from. In a sense, in the bottom, coming from the bottom of the left atrium. For you, it's not a big deal. For us in EP, it is. Because if we are going after a spot that's firing very fast and causing problem, it helps to know before we start if we're going to go to the left atrium or stay in the right atrium or go somewhere else. So it helps to know, and it's also a joy to know where things are happening and how it's happening. If you look at this strip here, narrow QRS, supraventricular, sinus, atrial, or junctional. No P wave, exclude sinus or atrial, you're left with junctional. So this is just a nice display. And look how this rate did not change at all. This is just the sinus node decides to slow down, and the atrial rhythm, which you can think of as escape atrial rhythm, took over. The patient will not feel it. You check the pulse, doesn't make any difference. And the junction here is taking over simply because there is no sinus node. So these are nice rhythm. These are escape rhythm. What do we do about them? Nothing. Just enjoy the fact you can distinguish them, and the patient has them as a backup rhythm. And there's no specific therapy other than making sure there's no reversible cause for the sinus node to be slow that you can reverse. And if you have sinus node dysfunction, that's been symptomatic because the heart rate slows down too much, that's when you may need to think of the possibility of needing a pacemaker. This is another practice ECG. I usually have you guys do it, but I'm going to enjoy doing it myself. So here, this is the best place to be for 12-lead ECG. And you can see the speed and the gain in one corner. You can see the test, 1 millivolt. QRS, look at it, narrow. And this to highlight another thing. RSR prime, or rabbit ears, we always look at them and say there may be a right bundle branch block. The point I want to emphasize on, it doesn't matter if this patient has RSR prime. If the QRS is narrow, 100 millisecond or less, it is not bundle branch block, regardless what the shape of that QRS is. Narrow QRS excludes bundle branch block and tells us it's supraventricular rhythm. Let's look for the P wave. Lead 1, I don't see a P wave, and you think, oh, is that junctional? But you look at lead 2, you see nice P wave. That's inverted, so it's going away from lead 2, from the bottom up. This is atrial rhythm. So this is basically a simple way of looking at a 12-lead ECG and decide it's supraventricular rhythm, and a quick look for a P wave or lack of P wave in lead 1 and lead 2. We can quickly decide if it is sinus, atrial, or supraventricular rhythm.